You know, we call these Sunday afternoon sessions from St. Basil's conversations for our times. And as the name implies, we spend time having a conversation on a topic that is of particular interest to us right now. We invite someone with expertise in the subject to bring us up-to-date information and lead us as we ask questions and discuss implications. That's exactly what we're doing today. Social isolation and loneliness has become a serious concern, heightened by conditions during the pandemic. And now, as we face the oncoming restrictions of winter, it's even more important. And we're extremely fortunate to have Dr. David Conn with us for this conversation. Dr. Conn is a geriatric psychiatrist at Baycrest Health Sciences and a professor of psychiatry at the University of Toronto. He's founding co-chair of the Canadian Coalition of Seniors Mental Health. He's received numerous awards, both nationally and internationally. Dr. Conn, we're really happy to have you with us, and we welcome you to our conversation.
Thank you so much, Elizabeth. And I want to thank all of the organizing committee, and thank you, Father Winkler, for that lovely introduction to today's session. I want to thank Dr. Andrew Wiens as well. I know he's a member of your congregation, and he actually was the first to approach me about the possibility of setting up today's conversation. So I'm going to share my screen, and there we go. Okay, so it's a big topic. So I have a lot to say, but I'll try and keep it to, like around 25, 30 minutes, and then we'll have lots of time for conversation and discussion. And it is all about connecting. So hopefully today's meeting and session will make everyone feel connected, and even though we're doing it through familiar technology, of course. And again, thanks to the organizing group. It's lovely to be with you today. The Canadian Coalition for Seniors Mental Health. I just wanted to put a plug in for our coalition. It's connected to the Canadian Academy of Geriatric Psychiatry. The coalition is more interprofessional and extends beyond health professionals as well to the public. So if any of you have a real interest in seniors' mental health, you can join as an affiliate. You can become an affiliate member of the coalition. And the website's up there in the top left, ccsmh.ca. And yeah, it's free. And then once you join, you get all of our materials, and which include, although our primary work is providing information to health professionals, we try to have a lot of materials for the general public as well. So please join. It's totally free. And we're 20 years old, 21 years old. We like to always note whether we have any conflicts of interest. I don't, but I do mention that I have research grant support from a number of agencies and organizations, but no industry, no pharmaceutical industry. And the work I'm going to be talking about today, much of it on social isolation and loneliness, was actually funded through an anonymous foundation that approached us a few years ago. And this foundation who insist on remaining anonymous, have a real interest in this topic of social isolation and loneliness. I'm hoping that by the end of today, you'll be able to list negative health impacts associated with social isolation and loneliness, and be aware of developing international approaches to reduce it, and to be able to assess factors that contribute to social isolation and loneliness, and actually consider helping others or yourselves to make positive changes in relation to this. And this is just an outline of what I'll go through. I won't read it, but I will talk a little bit about our current project, which is actually creating clinical guidelines, in other words, practice guidelines for healthcare providers and social service providers around what we as clinicians can actually do in this area. And as far as we know, no one's actually ever done this before, which we could talk about later. So, and of course, we want to talk about interventions, what can make a difference, what can help. So Mother Teresa said that the most terrible poverty is loneliness and the feeling of being unloved. And I note Father Winkler's introduction about love and love of God, and some of the beautiful words that you used today. So the US Surgeon General, his name is Vivek Murthy, and He was the Surgeon General for a while, and then he got kicked out by President Trump, and now he's back again under President Biden. And he has a real interest in this topic and has written a lot about it. And he says that we live in the most technologically connected age in the history of civilization, and yet rates of loneliness have doubled since the 1980s. So that's quite telling, isn't it? So we use these two words together, or three words actually, but social isolation as one concept and loneliness as another. And we tend to just lump them, they sort of rolls off the tongue as one thing, but they are actually two different overlapping concepts. So social isolation is a measurable deficiency in the number of social relationships that a person has. So it's something you can measure, and based on the number of contacts you might or might not have. Whereas loneliness is an internal subjective experience. It tends to be an unpleasant sensation. And it's felt when a person's social relationships are lacking in quality or quantity compared to what they actually desire. So one's very objective, the other's very subjective. And it turns out that although they overlap, they're not the same thing. So you can have people who are not isolated at all, but they are very lonely, and vice versa. So that's very, very important to know. And there are different types of loneliness that have been described. Social loneliness, which does relate very much to a dissatisfaction with the quality of relationships. Emotional loneliness, or the absence or loss of meaningful relationships. So they don't relate it to a deep need that we have to belong. And then another term that's been described is existential loneliness, an aspect of the human condition which expresses the separateness of the person from others. So that's been written about a lot, how we come into the world alone and have to exit alone, and the universe is vast. And so one can feel kind of separateness. This is just for you to reflect on, but did you personally experience some degree of social isolation during the pandemic? And did you actually feel lonely for significant periods during this time? Has a doctor or other healthcare provider ever asked you if you're lonely or isolated? When I ask health professionals these first couple of questions, it's really surprising. And when we actually get the data, it's really interesting how many say yes to both of those first two questions. So Frieda from Reichmann was a German-American psychiatrist, and this is a quote from her. So she said that she noted a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject. This is back in 1959. And she says, thus it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. And she says that loneliness seems to be such a painful, frightening experience that people will do practically everything to avoid it. And just to back up what she was saying, I have a copy here in my hand of the DSM-5. You see how big this book is? It has 1,050 pages in it. It's huge. And there's only one mention of loneliness in the whole of the 1,050 pages. And that appears in relationship to, not surprisingly, but to people who are experiencing prolonged grief. It doesn't appear anywhere else. So on the right here, we have the words from the Beatles, Eleanor Rigby, very moving, evocative words. And, Eleanor Rigby died in the church and was buried along with her name. Nobody came. Father Mackenzie wiping the dirt from his hands as he walks from the grave. No one was saved. So, and the painting on the left is by an American female, Kay Sage. And I think, art is for interpretation, of course, but my guess is that she's expressing some degree of isolation or loneliness here. And then when you actually read about her history, that definitely fits. And she was married to a French surrealist painter by the name of Yves Tanguy. And after his death, she became very depressed. She had a lot of physical issues. And she actually took her own life. She committed suicide. So as Elizabeth mentioned in the introduction, so the pandemic has really shone a light on this issue. And this is an image from the British campaign to end loneliness. And I think, like I say, we all experience some degree of isolation and loneliness during the pandemic. I was at the Art Gallery of Ontario yesterday, and this was a painting that struck me. It's by a painter who goes by the name of Cos, although his actual name is Brian Donnelly. There's an exhibition right now at AGO, and this was one of his paintings that spoke to what was going on during the pandemic. So how common is social isolation and loneliness? So actually, studies are quite inconsistent, and it all depends how you survey people, of course, and what questions you ask. And it's generally assumed that loneliness increases with age, but actually there's a lot of evidence lately that it's younger people who are reporting the most loneliness. So what is the data, in fact? And so this is from the Angus Reid survey before the pandemic. And what you see here is that, and this is people of all ages across the country. And what you've got there is if you add the two columns on the left, you have just under 50%, 48%, either saying they're very or somewhat lonely. Pretty high numbers. This is data from the Canadian Longitudinal Study of Aging. So this is all related to older adults. I was told some of you actually participated in contributing data to this. But what we see here is over 3 time periods, with the third time period is the pandemic. And there is quite an increase, particularly, well, actually right across the board, but you'll see it's women who are reporting more loneliness than men in general. That's a common finding, and a real increase, as you can see there, during the pandemic. And this is very recent data from National Institute of Aging Canada. And interestingly, they said that Canadians aged 80 and older are the least likely to report social isolation. And that surprised me. And even more detailed data that supports that from within this survey. And they looked at individuals 50 years and up into different categories. And the 50 to 64 group actually had a lot more loneliness than the other two groups. So that's interesting. What about in different countries? Again, it depends how the data was collected. But this is rather surprising data, I think. And it suggests here that Mediterranean countries, with Greece really sticking out there, as you can see, seem to have higher rates of loneliness than other European countries or the United States. And that really does surprise me. And I don't know about what you would think about that. I'd be interested in your perspective on that. But I wonder if it's people in Mediterranean countries are just a little bit more willing and open to discuss their feelings and emotions as compared to Northern and Central Europeans. So what makes us healthy? So we call that the core determinants of health. And this is from Health Canada, Public Health Agency of Canada. And as you'll see, there's a lot of things in here, including what are called the social determinants of health, which are vitally important. And you'll see around this wheel, they've got actually the social environment and social support networks as both being important. So it isn't surprising that social isolation is a determinant of health. And this is very recently from the New England Journal of Medicine, which is, one of the finest journals in the land, or in the United States, considered internationally to one of the top journals. And this was from one of the gurus in this field. Her name is Julianne Holt-Lundstad, and a colleague at Brigham Young University, really highlighting the fact that social isolation and loneliness could be seen as medical issues. I'll read what she says. Pretty important. Social isolation and loneliness are rarely listed on death certificates, yet they may have contributed to the excess deaths from all causes observed during the pandemic. Although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals into their existing responsibilities. Patients' lives may hang in the balance. That's a pretty strong statement. And this is data published in Canada by the National Institute on Aging, but this is from a lot of different studies. But this is scary. These are scary numbers. Look at this. This is your increased risk of various outcomes if you're isolated and or lonely. So And again, most studies tend to sort of lump isolation and loneliness together, but you've got a really significant increased risk of many medical conditions listed here: stroke, heart disease, cancer, general functional decline, increased risk of death, and increased risk of developing dementia. Just as an aside, just so that we can be a little bit balanced here, though, is social isolation, is it always a bad thing, a terrible thing? And just to contrast here, what about this concept of solitude, of actually being really comfortable being on your own? And I think most of us actually do cherish a little bit of time on our own, and we all have a different sense of what that is for ourselves, but there is a suggestion that being on your own, spending a significant amount of time on your own, can actually have positive outcomes. And you'll see on the left there, increased empathy and productivity, creativity, perhaps, I could understand that, mental strength, a chance to plan, good for kids, perhaps, and helping to know yourself. So, and is that scientifically backed up at all? This was a study published quite recently. And it says, the motivational profile of solitude and well-being among seniors. And they found, yes, indeed, that people who enjoyed spending time alone predicted personal growth and psychological richness, and that solitude appears to foster a particular type of well-being centered not around positive affect, but around psychological depth, or what scholars call a psychologically rich life. I think it's a really interesting question. What is the right balance? So I think it's important that we don't, say, people who are spending time alone, that's a terrible thing. It's a question of the right balance for each person, and each person has a different need for that, what that balance actually is. In general, though, on the other hand, there is an association, a strong association between loneliness and mental health. And I'll read a quote here that comes from the Harvard study of adult development, which is a very long study of adult life. And the quote is that close relationships, more than money or fame, are what keeps people happy throughout their lives, and that those ties protect people from life's discontents, help to delay mental and physical decline, and are better predictors of a long and happy lives than social class, IQ, or even genes. And that proved to be true across all sectors and social classes that they studied. Not surprisingly, loneliness is more common in marginalized communities. And this is from a chapter regarding the United States in a recent publication, a whole book on loneliness. So yes, so there's no question that, not surprisingly, loneliness is more of an issue with immigrants and really all marginalized groups. And here in Canada, there's actually a very good report specifically on Indigenous seniors in Canada, with a lot of advice actually, and around how those communities can help themselves and be helped. So there's a lot of very impressive reports and studies from different parts of the world on this topic. The one on the left is from NIA, which is in Canada. The one in the middle is from the National Academy of Sciences, Engineering, and Medicine in the United States, focusing on the healthcare system and this issue. And then again, in 2023, the US Surgeon General came out with a huge report on the epidemic of loneliness and isolation. Now, tongue in cheek here, but this is interesting in that in the future, when we all head out into space and head off to other planets and destinations, you can imagine that isolation is going to be a huge issue. And how, being cut off from communications, or the length of time for any kind of a communication back to Earth is going to be very long. And so how are we going to overcome this? And there's even studies. This is a study where they've done sort of practical assessments of what it's going to be like for astronauts who are spending long periods of time on interplanetary missions. So, and this is from Russia. So the Canadian Coalition for Seniors Mental Health, this is our project, which I mentioned is funded by an anonymous foundation. And the main outcome, one of the main outcomes really of this project, which is coming to fruition, ends in March, is the development of clinical guidelines for healthcare and social service providers. And And actually, we believe this is a first in the world, that no one has actually done this before. And probably because, there's lots of clinical guidelines for every disease under the sun. But social isolation and loneliness are not considered to be illnesses per se. They're social situations. And so no one's ever come up with this before, as far as we know. And so, you always start out with a literature review, and then we put together this really expert working group from around the country. We did national surveys with service providers and older adults themselves. And then in the future, we want to disseminate the guidelines and create toolkits and knowledge translation products, generally raising awareness and strengthening networks. So this is a list of my colleagues who've worked on this project. They're from coast to coast, and they're interdisciplinary. And we have a great staff who've worked on this with us. Claire Checkland is our executive director, and she's based in Ottawa. She's terrific. And I just wanted to mention the survey that we did of older adults from across the country, and this was carried out a few months ago. And we just want to understand how older adults perceive this issue, and particularly we're interested in their comfort in discussing this issue with health or social service providers, and questions specifically about how they stay socially connected. So this was in background information for us in developing the guidelines. And we actually had more than 2,000 respondents, which is really good. More women than men, not surprising. And you'll see the age ranges there. So right across the board. So this was really interesting. 94% that they're somewhat or very aware of the negative impacts on physical health of social isolation and loneliness. An equal number were aware of negative impacts on mental health. Just over half would be comfortable discussing this with a healthcare provider. And the other half that would not be comfortable said that it would be embarrassing. There wouldn't be enough time for a doctor to pay attention to this. And you're only allowed one issue per appointment, which is often true. And they said that their provider, though, could, to help provide resources, connect to community programs, suggest activities, take time to talk about the issue. And what would they actually do? They would spend time in person with friends and family, exercise, use technology to connect, spend time in nature. These are really good responses. Not that many said they would talk to their family doctor or nurse practitioner. Just a few things you might wonder, what sort of stuff is actually in a clinical guideline, right? So we have ideas about who should be screened, the kind of instruments or tools that you can use when screening. But one thing we said was that if you're assessing a person who says they're very lonely, for example, that you need to do a good assessment, not just say, okay, you're lonely, let me suggest A, B, or C. But you really need to understand what might be going on for this individual to explain it or try to understand it. And so we listed a whole group of things you have to think about that could be affecting and influencing this problem, as you can see listed there at the bottom. And so mental health, for example, really critical, right? I mean, if someone's deeply depressed and that's why they're staying away from other people, then we have great treatments for depression, and that would be the best approach. Or they have a condition called social anxiety disorder. That's a very specific illness with very specific treatment. So, it's important for us to actually try and help the person with whatever's causing the problem. Or what about if they have just really bad hearing and they're not willing to get hearing aids? Well, that actually could be hugely influential. So all of these things are discussed in the guidelines. And then when it comes to how we help someone after doing a good assessment, we emphasize that we need to use shared decision-making and an individualized approach. And the clinician should try to understand the person and their interests and what might be a good fit for them, when we're talking about resources, taking into account an individual's culture and recognizing the diversity of our population. And then, as I said before, treating underlying conditions as well. And so some of the interventions we actually recommend and talk about are listed here. And again, I don't think any of these would surprise you. Now, social prescribing is top of our list, and that's become an increasingly popular type of intervention. So what is social prescribing? Well, sort of you know, how a doctor uses a prescription pad to write out, well, actually, they often do it online now, but the prescription pad where they write the name of the medication. Well, the idea here is that instead of prescribing a medication, they're actually prescribing some sort of social intervention. And that's developed now into a much more sophisticated approach where the primary care provider can refer a person to someone in the community that's an expert in resources. We call them link workers. And that link worker can then work with the person and help them find the right connections, the right resources, the things that really interest them and what might be available in their community, and then actually facilitate connections and really encourage the person. So that's a whole new approach. And it's garnering quite a bit of interest and strength. Started out in the United Kingdom. Social activity is just broader, and it's the whole range of social activities that a person might be interested in. Physical activity is good for everything, and certainly good for this. And it's interesting, the studies suggest that, yes, of course, group exercise classes would be a great thing, but even individual physical activity seems to be helpful. There are a range of psychological therapies like cognitive behavior therapy that can be helpful, particularly for some people whose loneliness may stem from certain beliefs they have about themselves or others, and you can work to change those beliefs. We all know about the benefits of pets and animal-assisted therapies. Developing one's leisure skills, the things you're interested in, using technology to connect. And then we do address the issue of pharmacological treatment, because there's been some suggestion that you could actually treat isolation and loneliness with a drug. And we say that, no, we do not recommend that unless you're treating, an underlying condition like depression. And this may be of interest to your group, because what about religious attendance and loneliness in later life? And this was from a study that was published about 10 years ago in an eminent journal, The Gerontologist. And they studied this using a massive database in the United States, where they had data both on religious attendance and on levels of loneliness. And not surprisingly, they found that involvement in religious institutions may protect against loneliness by integrating older adults into larger and more supportive social networks. So you may say, wow, we didn't need a massive study to prove this, but it's really nice having that study, having that research. This is from Europe, and it's just a sort of simple poster that says, these are some things you can do to alleviate loneliness. And all of these things make sense, of course, and wouldn't surprise any of you, but it's nice to see it sort of listed here in a very easy to digest way. And at the bottom, on number 6 there, it says, seek professional help if loneliness is causing significant distress. And, I think many people can alleviate some of their loneliness without seeing a professional. But, if things are getting really, really bad and the person's perhaps depressed and lonely, or there are other situations or conditions that are contributing, then yeah, getting professional help makes a lot of sense. So, what can we do across society to help this problem? And this pyramid suggests that, you can address this problem from multiple perspectives. So the individual themselves, of course, can do something about this. People who are lonely can make changes in their life. Whoops. And we would always encourage that, right? No question. If somebody can take charge of their own life, that's great. But then what about communities as a whole? Can they actually do something to reduce loneliness in the community at large? And then society at large, where governments and health authorities and so on can help. So we can think about interventions at different levels, right? And I think that's an important way to think about this. And this is interesting. This is actually from the Netherlands. And I saw this on the BBC. The BBC actually did a huge survey of people from across the world on their levels of loneliness some years ago, which was interesting. I think they got 50,000 people to send information into them. But this particular article, online article, focused on a particular situation that happened in Rotterdam, where a woman was found in her home who had been there for 10 years. I know you're thinking that's impossible. Like, surely someone would know or have noticed. But in this particular case, no. And they had 10 years of accumulated mail to figure out when this person had died. And this got national attention in the Netherlands. And people said this is symbolic of how serious this problem is, this problem of isolation and loneliness, and people just being totally alone. And that spurred all sorts of local initiatives in the city of Rotterdam, and then that spread nationally within the Netherlands. And they've done a lot of things that are simple but practical. And one of them was a scheme that pairs animals with lonely people and gives them practical support to make that happen. And I think part of that is actually people who want to kind of share their dogs with others and sort of realize that there's some people who, you know, spend the whole day at work leaving their dog alone. What about if they had someone who could help to walk the dog and spend time with the dog and sort of shared ownership, if you like? So lots of practical things. I know some places have had there's a park bench there. A lot of people in some places there are signs saying things like happy to chat, you know, saying if you sit on this bench, you know, this is a bench where people can chat, give permission for people to chat with each other. I know another initiative in some parts of the world, including I've heard in Canada, was supermarket checkouts where they have a separate lane for people who are not in a rush and would quite like to have a little chat with the cashier. This is from the US, from that report from the Surgeon General, who says these are 6 pillars in terms of our approach to this problem of improving social connection across society. And you know, it ranges from strengthening social infrastructure in local communities to public policies in general, mobilizing the health sector, which, you know, we are doing as our coalition, and doing more research and generally building a culture of connection, which is quite a task, of course, but that's what Vivek Murthy would like us to think about and to do. So we're talking about change, we're talking about improving things. I love this slide, you know, it says, who wants to change? And who wants change? Who wants change? Everyone puts their hand up, and then who wants to change? Everyone's a little quiet at that time. So change is difficult. It's hard, it's really difficult. I wanted to mention this approach, which is from Nova Scotia, actually. I have colleagues in Nova Scotia who started this. It's called the Fountain of Health approach. And it's all about setting little goals for yourself and documenting them and following up on them. And the Fountain of Health actually was designed to help health professionals help their patients by giving them the right tools to encourage people to make positive changes of lifestyle. And it's proven quite successful. And it has all sorts of materials on their website about how to make positive lifestyle changes. So if you're interested in that, you can find great stuff at fountainofhealth.ca. So I'm going to finish up now. So this is just some key points. So there are multiple perspectives and theories regarding social isolation and loneliness, and that the prevalence data that we have related to age, gender, and culture are actually inconsistent. And of course, the strong association between social isolation and loneliness and poor health outcomes, that our clinical guidelines will be the first to address this issue. And there are many possible interventions for both people themselves, but also for social service and healthcare providers to consider. That we must take an individualized approach, recognizing everyone's different, and shared decision-making. That solutions are possible at the society, community, and individual level. And one thing I didn't specifically talk about, I mentioned the Netherlands there, but there are a few countries in the world that have really taken a leadership role, and many of you may have heard that the United Kingdom appointed a federal minister of loneliness I think about 6 years ago, and that they've had a huge campaign to end loneliness across the United Kingdom with some really interesting approaches. And yeah, I do ask the question here, what approach should Canada take? And should we actually have a national campaign or a provincial campaign or just local campaigns? I'd actually be very interested in your thoughts on this. And I'll leave you with a quote from John Lennon. So you may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us and the world will live as one. That's my email address if you have anything you'd like to send to me or connect. I've also put up Betty Watson-Borg's email. She's our project manager. And the red is, again, the website for ccsmh.ca. And if you'd like to join as an affiliate, like I say, please do. And yeah, let's talk and let's connect. So I'll stop there. I can stop share. Yeah, there we go.
Okay, thank you very much, David. And to continue the Beatles theme, I think I maybe start these questions by saying, in the absence that all we need is love, can I ask you just to deal with a few very technical questions before we open up? There's a lot of more kind of thought expanding questions, but there's a few technical ones. Yeah, you began very early with a big, thick book in your hand, and we're used to holding big, thick books, but I think your big, thick book is a different one. Can you explain the significance and the importance for you and for us of that book called the DSM-5?
Be happy to, yes. Yeah, so this is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revised, DSM-5. So for a long time, mental disorders, psychiatric disorders, mental disorders were not categorized very scientifically. But over many decades through research and really trying to understand different illnesses, we got better, I think we've gotten better at trying to figure out what the actual illnesses are and how to recognize them and how to diagnose them. And so for each mental disorder that's been recognized, there are a list of criteria. I'll give you an example. So as a physician, as a clinician, as a psychiatrist, depression is one of the most common disorders that we deal with. But what is depression? Many of us have depressed days, right? You may have a day where you're not feeling great. Actually, right now, this is a very depressing time for many people living in countries like Canada and northern countries because of the lack of daylight and the short days. Most of us feel a little grouchy, a little not quite as good as usual, not as peppy, go into hibernation mode. Is that an illness? Mostly not an illness, although some people suffer from seasonal affective disorder, which is just that. When winter comes, the late autumn, early winter, they start to get truly depressed. And that actually, one of the great treatments for that is bright light therapy. You actually purchase a bright light that can actually lift your mood rather than a drug. So, but that's a disorder. There's a whole range of different depressive disorders that have different criteria for diagnosis. So it's not a single condition, but the thing that we really try to focus on would be a major depression, which is something that we usually would want to treat one way or another. And to get that diagnosis, you have to have at least 2 weeks of serious depression that's affecting you significantly. And there's 9 different symptom groups listed, and you have to have 5 out of 9 for at least 2 weeks. And that's the sort of stuff that's in this. It is kind of like a Bible of mental health disorders. And then so for us, for those of us sort of psychiatrists and other health providers, this would be the book we go to figure out, what a person may be suffering from in an organized fashion. And interestingly, though, as research emerges, as we produce more and more research and more understanding, there are gradual modifications. So, and we would hope improvements in this document.
Thank you.
There are committees that discuss all of this great length and review, and then come and then make changes.
Thank you. Can you untangle a fascinating phrase you used? You talked about the difficulty in talking about loneliness because of the beliefs that some people have about themselves. Can you explain what you're reaching for with that?
Yeah, well, that's getting at issues like self-esteem. So some people, for whatever reason, don't think much of themselves, and this may emanate from early life experiences. Perhaps they did not live in a very positive family. Perhaps they had parents who were not very loving and supportive. And that can have a profound impact later in life, of course, in how you feel about yourself. So we're getting into sort of the depths of psychodynamic therapy sometimes, where you try to untangle early life and relationships and how they're affecting your current relationships and your view of yourself and others. And not surprisingly, some people who don't, view themselves very positively may find it difficult to have relationships, positive relationships with others, and may withdraw, may become more lonely, more isolated. And other people may have unsuccessful relationships because of experiences they had early in life that were turbulent, perhaps. So psychotherapy, talk therapy, may try to untangle that. And there are different types of therapy that would take different approaches. But CBT, cognitive behavior therapy, tries to help a person make corrections to their thoughts about all sorts of things, but about themselves and others and the world in general, with the help of a therapist and by really trying to do a lot of self-analysis and homework. So, yeah.
Okay, thank you. This is a straight post-COVID question. The questioner says, I rely more and more on virtual socializing, as I and my elderly friends are less able to travel to see each other in person. My virtual friendships are deeper than the relationships with more casual neighbors, fellow church members, and so on. And here's the question. How do professionals assess the value of virtual versus in-person contacts?
That's an excellent question. So, and I think there's sort of two aspects of that question. I mean, one is the experience that we as professionals have had throughout the pandemic, particularly working in a field like mental health, where you can assess someone virtually and you can treat them virtually. And there's been a huge movement now by psychiatrists and psychologists and social workers and others to see people virtually rather than in person. And in fact, I know some psychologists who have sole virtual practices now. They don't want to bother having an office. Well, you have to pay for an office. It's expensive. I can have a good practice without seeing anyone in person. I don't really think that's a great idea myself, because I do think there is a qualitative difference between sitting with someone in person versus a virtual connection, virtual assessment. Even though, I mean, Zoom works really, really well. Personally, I've been doing virtual consults to Northwest Ontario for over 20 years. So I was kind of one of the early adopters of virtual assessment in psychiatry, and I've always really enjoyed it. But that's 2,000 kilometers away, so it makes total sense. But to be seeing someone virtually who's living around the corner, I don't know. It is convenient. I think it's good for older adults in the winter, when there's a terrible snowstorm. But I don't think, I think it's useful as an adjunct, but I don't really support the idea that it completely replaces face-to-face care. And then the other sort of side of that question, I think, relates to just our social relationships in general, nothing to do with professional practice or treatment, but many of us have, adopted a lot of virtual contacts now, again, because of the convenience of it, and it's a great way of connecting with people. Maybe you have, friends, colleagues from all over the world. You can connect with them through Zoom. It's remarkable. So it's an amazing technology. But I think it's second best. I think it's second best, but in many ways, it's a good alternative. And for practical reasons, it can be great. And many of us, I play bridge, right? And many of us now who play, I bet there's some bridge players in your group, right? You can play on Bridge Base online, and it really works very, very well. You can play duplicate type bridge, and you can learn from everyone else who's playing at the same time. It's remarkable. So I think there's some real benefits from it, but it doesn't replace in-person. Everyone comments, my colleagues, I got together this week with a university committee that we have not met in 4 years. And we had lunch together this week, right? And everyone loved it. And everyone talked about how fantastic it was to sit together and spend time together and how different it was.
I have a question here that relates to what I would call the medicalization of
Yeah,
this issue.
that's fair.
And it raises the issue of our relationship to the medical profession. And this is what the question writes. I've heard from many women that if they raise this type of issue with the doctor, they dismiss it just as this is in their head, and so they give up raising it. Is there a movement, the questioner asks, is there a movement to have doctors more aware of the importance of taking such issues seriously?
Definitely, and that's one of the missions of our work, this work that the Canadian Coalition is doing. And yes, I think that is a huge question and very important question and comment, because I mean, traditionally medicine was focused very much on physical illness, physical problems, and your license to get into a doctor's office, it always felt like you needed to have something physical, a physical complaint. And to go in with concerns about depression or anxiety or loneliness, I think many people felt a stigma there. They felt that a certain sense of shame, perhaps, or weakness, or the doctor's not going to be interested or take it seriously. And so it's all part of the larger issue around stigma associated with mental health issues. And I think things are getting better. I think doctors are getting better. I think younger doctors in particular have learned how important this is. In certain areas of medicine, we take a biopsychosocial approach. All of medicine should take a biopsychosocial approach, but obviously in areas like psychiatry or geriatrics, that's what we're trained to do. That's what we train others to do. That is the emphasis, that psychosocial issues, psychological issues are just as important as physical, biological issues. But a lot depends, I think, on the individual doctor. I think it depends on how much time a doctor has to spend with you. And I'm sure that does happen sometimes, that it's difficult to bring up those issues. And I think some doctors don't know enough about these areas and don't sort of feel helpless. And so our mission is to really change things. And we have a family doctor on our group, on our working group. Her name is Amy Friedman, and she's written about this widely. And she wrote a paper in the Canadian Medical Association journal, or was it the Canadian Family Physician? One of the two, with a colleague. And in medicine, we talk about issues that affect older adults as sort of serious common issues. They're called geriatric giants. That's the term. And her thesis in this paper was that social isolation and loneliness is the new geriatric giant. And that was actually the name of the paper. And the editors liked that and published it as such.
Can I jump in by putting two things together here? Somebody has just given a statistic that links directly to a question. The senior population is expected to rise by 68% over the next 20 years. Governments and publicly funded agencies are already behind the curve. We have to look after each other, is the statement. But flip that to the next line, which is a question from somebody else that says, but the struggle is helping someone who maybe does not want to be part of the solution, but is definitely experiencing social isolation and loneliness. And so here is the question: how can someone help people such as this?
So it's people who are resistant to any kind of help,
who are not necessarily interested in being invited into this kind of conversation.
Right, right. I mean, it depends on your relationship to that person, I suppose, and just how concerning the issue is. I mean, I always come back to this individualized approach idea that each one of us is really ourselves with our own personal story and narrative and history and world around us and connections and community, and it varies a lot. But people who are very isolated worry us a lot. And as if it's a friend, for example, or a relative, I think the best thing would be a sort of private conversation with that person, quietly expressing concern and asking if there's anything, getting the perspective of that person, I have a patient who has not been out of her apartment since the pandemic began, literally, and she doesn't have family and she's very alone in the world, and she tells me she's not lonely. Interesting.
I have a simple technical question and then a very complicated question that is very simple but complicated that will follow. So the simple one is, how do you define social infrastructure, please?
Social infrastructure.
This is a reference to, you talked about it in relation to, I think this is to do with networks and the different, dynamics around us.
Yeah. Well, infrastructure, social infrastructure is a sort of combination of the relationships that you have, but literally it's the whole world around us and everything that we see and are connected with. And that involves all aspects of community and different levels of organizations and government. And it's really the whole world around us and how we're connected to it or not connected to it.
And the complicated but simple question is loneliness and social isolation different for men from women? Is there a difference? And can you comment on that, please?
Yeah, so there is data that women are more likely to, and I think I mentioned this, women are more likely to acknowledge loneliness than women are more likely than men to acknowledge it. I think that goes with really, all components of and aspects of mental health, in that men in general are less well connected to their emotions and less open to discussing them. And there's a term that we use in mental health. It's called alexithymia, which comes from the Greek, meaning no words for feelings. And there are people out there at the more extreme end of things who literally cannot describe feelings and emotions. They just don't, it just doesn't connect, and they don't want to. And they'll express their emotions and feelings in different ways, but they could never talk about them per se. Often more likely, for example, if someone like that gets really depressed, they're almost invariably going to present with headaches or weakness, fatigue, some other kind of pain, but they won't be able to say they're depressed. So men are more likely to have alexithymia than women. So I think there's been less attention on men in relation to mental health and in general, but there've been some new approaches. So some of you may have heard of men's workshops. That's been a whole developing community initiative where they set up particularly where older guys who've been woodworkers and can actually come together and work on projects with each other in a way that they can find easy to do. So
thank you. I'm going to, as you answer this next question, I'm going to invite, I know that there are some participants who want to raise questions for various reasons, who want to do it online, who want to do it through a microphone rather than online.
that would be great.
So if you are in that group, can you let me know? Either send me a note through the moderator or raise a flag. I'll try to observe the screens, and I'll invite you and switch your microphones on to do that as we proceed to the next cluster of questions. This next question actually relates to an earlier one that came up, and that is to do, there's a the first one is, I am curious if some studies also have statistics for other areas in the world, Asian, African, South American countries, and not just European or North American, for example. And here's the question that comes from that. Are there many differences between social isolation and loneliness within different cultural communities?
Right. Yeah, so there was a paper published a year or two ago in the British Medical Journal, and the title of the paper suggested that they had data from over 100 countries around the world. And when I saw the title of the paper, I was really excited. I said, finally, we're going to get some really good data. And but most of what they said in this paper was that they didn't have good data, and it was actually quite disappointing. But I think the best answer to that, we don't have great data from a lot of countries around the world, interestingly. But I mentioned earlier the BBC that had done this massive survey of people who are using the BBC. Now you could say, well, that's a sort of biased population for sure. But yes, they got numbers from, I think it was over 200 countries. And so what they did was, there was a paper published on this particular survey. And what they did is they grouped countries together they categorized countries, and I don't know quite how they did this, as being more focused, let's say, on individualism versus collectivism, where people are more working together and connected as communities, versus countries that focus very much on an individualistic approach to the world, and it's all about me. Perhaps the country just south of us might be a country that would epitomize that. But what they found, not surprisingly, was that there was more loneliness in general, on average, in the countries that developed more of an individualistic approach than a collective approach.
A few months ago, in one of our conversations for our Times, Dr. Christopher De Bono talked about medical assistance in dying. And we had a very involved conversation about that. This next question relates directly to some of the things that he was talking about. Here it is. With the government inclusion of more and more acceptable reasons for medical assistance in dying, for example, loneliness, is there a concern that seniors might be disproportionately impacted here?
Yes. Well, that's a fascinating question. So as was, I'm sure, discussed in that session, and as I'm sure you've read in the media, we are liberalizing or widening access to MAID, medical assistance in dying, this year. In fact, on St. Patrick's Day, March the 17th, 2024, unless something changes, the federal government will now allow for medical assistance in dying solely on the basis of a mental illness, mental disorder. And that's new. And that's raised a lot of concerns right across society, I think, certainly amongst psychiatrists. And I'd say there's conflicting views. People have very different views about this. And a lot of people, I think, have serious concerns. I was at a presentation about a month ago that looked at this question, and we had an expert speaker from the Netherlands, where they've actually had that particular criterion for MAID, so solely on the basis of a mental illness, for quite a few years now, and he talked about it. The good thing to hear about was that the numbers actually have been really small, so it hasn't happened that much. But the argument for it is that, people who have, let's say, unrelenting depression that's causes enormous suffering and dysfunction and hasn't responded to treatment, maybe those people have a right, just like people have a right now for MAID based on other criteria, more physical illness. So, but yes, I think, actually, if you look at MAID data for Canada, it is mostly older adults who are asking and getting medical assistance in dying. And there's reasons for that, and it's not surprising, of course, but as people age, we're more likely to get cancer and more likely to get severe illnesses that reduce our quality of life dramatically. So, but yeah, I personally have concerns about it, and I hope that we'll be able to put in safeguards. The biggest concern I have is that with this new approach, which says that you can have MAID solely on the basis of a mental illness, it doesn't mean that a person has to have had extensive treatment before asking for MAID. A person can say, I don't want treatment. I've had a few treatments and I don't want any more, and I'm not prepared to have any more. And they have, and as you might expect, they have a perfect right to say that. And so there some people may end up with medical assistance in dying for whom there would have been a really effective treatment if they'd agreed to it.
Can we shift away then from that with this next question, which takes us back to culture and cultural differences? This question is asked because some cultures have a different approach to how they deal with their elders. So I just wondered if any of that cultural mindset can be seen in research. In other words, different cultures. I think this is particularly significant in terms of indigenous cultures and second, third language.
Yeah, I think, there are many cultures, at least traditionally, where elders are extremely respected, and the wisdom of older adults is really a part of their belief system and really respected. And just the term elders, for example. But that's been diminishing quite a lot in all cultures, I think. And in places where traditionally older adults were cared for within the family nest, that's happening less and less now. And so, but I think cultures where older adults are it's accepted that they'll remain at home as long as is humanly possible, supported by the larger family and with grandchildren and great-grandchildren. I mean, that's a beautiful thing. If it, and I think that's wonderful if that can happen. But in our current society, it's happening less and less, unfortunately.
This is perhaps an optimistic question, but are you optimistic that given the tensions and the difficulty that Canadians have in getting access to a GP, that in a sense, the medicalization of these issues adds a further challenge?
Yeah, and I don't want to overly medicalize it as well. I think that it sounds like we're medicalizing it by saying it's a medical issue, right? But it's not just a medical issue, and I want to emphasize that. So we think that the healthcare system can be a part of the solution, but by no means the whole solution. That's for sure. And so we think we can help to some degree, but I don't want to see, don't come away, please, with the sense that we're turning this into a purely medical issue, because it's not. And, yeah, we have a serious problem with lack of primary care providers, family doctors, nurse practitioners. And yeah, it's all very well for us to come out with guidelines that say, your doctor should ask you about this, but what if you don't have a doctor? That's very true. But we think that we're very deliberate actually in this approach to always emphasize not just healthcare providers, but social service providers and people working in community agencies and community centers and seniors programs right across society that we think can help with this. So it doesn't necessarily have to start with your GP or family doctor. I think there are many other places where help can come right across communities. And I think some of these sort of innovative approaches to this issue are not coming from within the healthcare sector. They're coming from, wider community initiatives where people are just coming together and saying, let's see what we can do. And I think the examples in the United Kingdom and Netherlands would be good examples of that.
As we're approaching the end of this question period, can we find out a little bit more about you, Dr. David Conn? How did you get involved in this area of engagement, and what keeps you in it? And there's 3 bits to this. How did you get involved? What keeps you in it? And what would you identify as some successes and difficult challenges that you have faced in this journey? Not a short question.
A lovely question. So a little bit about myself. So can anyone guess where I'm from originally? I wasn't born in Canada. No guesses. I actually grew up in Dublin, Ireland, and I'm a graduate of Trinity College Dublin. And then when I say Trinity College Dublin, you'll hear my Irish accent coming out a bit more. But I've been in Canada since right after medical school. I came to Canada, and it's a very good move, I think. And met my wife here, and we've been together now for a lot of years. And we have 2 kids and 4 grandkids. And yeah, and I've had a really, I think, rewarding career in geriatric psychiatry. It's been an area that's really suited me. I love working with older adults and helping them in any way I can. And I've been lucky in the institution I work with. I've had different responsibilities, and I've had a chance to do a lot of different things. But bringing people together in different groups and organizations, that's something that I seem to be quite good at. And so this Canadian Coalition for Seniors Mental Health has been one of my most rewarding experiences, which we started 20 years ago. And we basically had a big meeting in Toronto, and we brought people from across the country to look at the whole issue of seniors' mental health. And we brought all the different professional groups and industry and government and seniors groups into one meeting place. And we had all sorts of, we used a concept called open space. And it was an interesting organizational approach to this, but it gave everyone a chance to contribute and to plan together. And at the end of several days of meeting, the main outcome was, let's form a coalition, which none of us knew how to do, but somehow we did it. And I think it's unusual that we've survived for over 20 years, and we keep getting funding from different bodies and mostly national government bodies. But So that's been really rewarding, and I think we've contributed quite a bit in this area. But the area of social isolation and loneliness, I think that all of us so much during the pandemic that it was a real wake-up call. And then we were really fortunate that this anonymous foundation came to us and said, you know, this is a really, really important area, and we'd really like you as a group to consider if you could help in this area. Is there anything you could do? And we went back and forth with them and had all sorts of discussions. And eventually they said, yeah, you know, we want to fund you and help you to sort of create these guidelines and really try to make a change across the country. So I think sometimes things happen serendipitously, perhaps, but it was, I know if that foundation hadn't come to us, I don't think we'd be where we are today. So thank you to the Anonymous Foundation. I always think it's remarkable that certain philanthropists and organizations want to stay anonymous, and that's an amazing thing.
And no amount of money from us would encourage you to identify that entity.
Indeed,
right?
That's right.
Okay. Well, thank you, David Conn, for those very generous answers to those questions. I now invite Ellis Lynn Duchesne from the St. Basil's community to give a formal thank you for your presentation today. Ellis Lynn, over to you.
Dr. Conn, I'd really like, on behalf of everyone, to thank you for your generosity in being with us today, in preparing this material, and in talking to us. You certainly confirmed many of the concerns that we are all feeling about the effects of loneliness and the effects of social isolation. But one of the things you've really done is to separate those two so that we can see that they are not exactly the same, and that there needs to be a balance for people, and that different people will have different points of balance in that area. You know, it's very exciting that you have been able, as a coalition, to write these guidelines. We're certainly hoping that they will help the medical community and other people as well to think about this and to move forward. And you've given us some practical ideas about how we might think about this and what actions we might take. And if I may say so, it's a parish that likes actions. So thank you.
Thank you very much, and really enjoyed this today. And I thank you all for your really excellent questions and comments. And I want to thank Kevin especially for your expertise in chairing today. You're obviously very seasoned and expert moderator, so I appreciate that. So, and thank you all very much, and I wish you all the best in the future. It's been really nice meeting you.
Well, don't leave us just yet, because Father
Yes.
Winkler has the next action.
Right. And I hope I can do this. Let's see now. I have here an image of a medallion. It's can you see it? It's in the shape of a bear.
Yes.
That okay. So where I am right now, I'm not in Ottawa. My first cousin has passed away, and I'm on Manitoulin Island near Sudbury, in the Lake Huron. Anyway, the people, and my mother was Indigenous. She's a Native community here. And for us, for Indigenous people, the bear is an animal that represents healing, spirituality related to healing. And so we have, my niece has made this image of a bear. You can see it's walking, and it's beaded. This is a beaded. I don't know if I can make it a larger. Let's see. I don't know if, anyway.
Yeah, that's beautiful.
Don't know if I can. Let's see if that works. So there's an image of it a little bit. You can see the beading here. Anyway, and in the center there, it looks like a green. It's supposed to represent cedar, because cedar for us is also, it's what helped us survive winters. Cedar tea. It's rich in vitamin C and other nutrients. So in this image of this bear, what you see is the cedar branch. So it's all about healing. That's the theme of this medallion. And this is what we're going to send to you in appreciation for your gift of sharing what you've learned with us about loneliness and social isolation. So we'll send this to you as a thank you and gratitude for your time with us this afternoon. And we appreciate it. Second, and finally, you're welcome. We're so glad you were able to be with us this afternoon. Finally, just want to end with saying that our next conversations for our time will be in the near future. Please stay tuned. Stay tuned for our next conversations for our time. God bless everybody. Have a great afternoon. See you in the near future. Thank you.